It's hard to know how to follow Dr. Rodas. And if I had known Dr. Rodas when I was a student and a resident, I might not have needed to take the path I took to learn what I've learned. And I hope that I'm not going to say too much more about these things than Dr. Rodas has already said. But extreme affordability is a term that I learned at Stanford because, and you'll hear this keynote speaker tomorrow speaking more about extreme affordability. But the way I got to this idea was not from the University of Utah, but it was what I did on my summer vacation after I finished my board exams, after I finished my urology training. I had always wanted to do international work. I think I wanted to do this since I was in high school, and I thought that maybe the way to do this was with the Peace Corps, but I didn't have any skills, and I didn't know how to get those skills that would be useful to people in other places. So I went to medical school, and then I did a surgical residency that took 6 years, and then it was another couple of years before I passed my boards, and I thought, Eureka, great. Now I can go do something useful. And at that point, my mentor, who Dr. Rodas has already mentioned, Don Laub, was my professor at Stanford. And he had been going around the world with Interplast, teaching plastic surgery, and everywhere they had gone, they had been seeing little children with congenital abnormalities of their genitalia. And most people don't know much about this kind of thing because, like, who wants to talk about that? But it turns out it's a very common problem in little boys, more common than cleft lip and palate, more common than many other congenital abnormalities we know about. And everywhere the plastic surgeons had been going, they saw these little boys, and so Don said to me, let's go start something up in Honduras. So what I did on my summer vacation, my first opportunity was to go to Honduras and to go to San Pedro Sula, which was a very poor place in our hemisphere, one of the poorest. And this is the hospital we went to. Now this hospital had never had pediatric urology, but they certainly had a lot of patients. And the first person I met was the guard. Now, we are not used to seeing guards like this at the front gate, and especially not in front of the operating room. In San Pedro Sula, in this particular hospital, there was an armed guard at every door. It's a shock to most of us, but that's the reality in this place where people are living and working. And then, looking out the window, we saw these guys out there mowing the lawn with machetes. That's what they do to mow the lawn there, and this is what populates the emergency room. Machete wounds, something a little new. Something new to us at any rate, and I'd never seen anything like that. And then walking down the hall toward maternity, there are these ladies, 2 to a bed, 2 to a gurney, with their babies. And the place smelled horrendous. If we are used to a pretty clean smelling OR, I've never smelled anything like it before we went to Honduras. And this was a shock to see babies with huge hydrocephalus and spina bifida that we normally take care of here in the United States. I had never seen an evolution of these kinds of problems before. So in the space of about a week, I saw a lot of medicine that I had never seen before in the States. And it was a little bit scary because I didn't know what to do about it. This was my first patient. And this actually was a preteen boy. We operate on these children when they're 6 months old in the States, but in Honduras and in many other places, children are teenagers or older before they have the opportunity to have surgery. So we operated on this boy, and here he is afterward. There I am with him. And then we would go. We had, I think, about 30 patients on that particular trip that we operated on with our Honduran colleagues. And we'd go to rounds and we'd see the kids. And I remember one particular little boy was in his crib, and I went around first thing in the morning and I saw him, and his crib was right next to the window. And coming down through the window and up the crib and into his bed was a line of ants. And they were crawling over to my surgical incision. And this was, of course, highly distressing. And at the end of this whole week of doing these good cases, the best I knew how to do, I had already been training up these years, we had complications, and a lot of them. And it was very, very distressing. We had patients in urinary retention. We had patients in terrible pain post-operatively. We had no good perioperative pain management. We discovered that in this hospital in Honduras, they didn't have narcotics available for patients post-op. They didn't have specialized pediatric anesthesiologists. They didn't have all those things we depend on to have really, really good outcomes. And so we went out to see, well, where did these patients come from? Well, this is the kind of home where they live. We were staying in homes that had guards, of course. The hospital had guard. But there were other realities. What are these? Cholera cots. Cholera is endemic, or was at that time, in Honduras, and these are iron lungs. They were in the back of the hospital, and nobody wanted to get rid of them just in case they needed them again. So they kept them. And I think they've finally removed them now. So I thought, well, maybe we just need to do it better. Maybe we really need to rethink this whole thing. We were having bad outcomes, and it was disappointing, and it was kind of scary. And so we called on our colleagues. And we called on our colleagues from Canada, and we brought them from Toronto. We brought in the pediatric anesthesiologists who were really, really skilled to figure out, well, how can we do the anesthesia better? And how can we bring in the nurses, the equipment, the supplies, all the things we need to prove that we can do this better? Because we know we can in our own hospitals, and without all these complications. How do we do it in a place like Honduras? What's necessary to do? So we brought the teams. We brought the nurses, and the nurses were wonderful, and they worked with our Honduran colleagues. And we brought our colleagues from here. That's Pat Cartwright a while ago. He came just afterward, and we thought, well, okay, we've got our good colleagues, we've got the people we know how to do these operations, but it's not going to be sustainable to just bring teams. We need to teach it, and we need to teach it better. So we started to try to figure out, well, how do you do that? And we came up with this idea that we would do procedure-specific training trips. At least people would be very, very focused on learning how to do one thing really, really well. And we needed the nurses to know what to do. How do you manage all the tubes? How do you manage the pain medicine? How do you manage to call the doctor if the patient's having a problem? You wouldn't think this is a big deal, but in many countries, nurses won't call the doctor. They won't disturb the guy in the middle of the night. And at that time, we didn't have mobile phones. Now everybody does. As Dr. Rhoda said, everybody has them and everybody gets called in the middle of the night. But at that time, they didn't. And then we needed to model the education in anesthesia and the patients. So there were a lot of things we thought we needed to do. And we started doing that. And then, as an evolution of this, we founded a nonprofit called IVU Med. which is based now here in Salt Lake City. And we wanted to do something, and we wanted to do that something really well. And that something happened to be urology, because I'm a urologist. And we wanted to make sure that if we were going to do it really well, we engaged all the stakeholders, everybody who could possibly have an interest in making this kind of surgery possible and available to people worldwide. So we engaged the academic training centers, the professional societies, that means the American Urological, the Pan-African Urological, the Société Internationale d'Urologie, industry partners, some of whom are here in this room, individual practitioners and public health organizations. All of these people have some kind of a stake in making this thing work. And we thought, okay, well, that's great, that's good. And we now actually work in about 30 different countries, and it's working great for education. But it's not all there needs to be. In the best places where we're working, this team approach works really well for patient care. And the training sites have developed their own outreach. In Vietnam, for example, our colleagues there, as a result of our working with them, now have their own fellowship program. They teach their own people. And Chad Wallace, who's one of our pediatric urologists, came last October, and we had a wonderful laparoscopic pediatric surgery training program that was an evolution from the very sort of thing I saw first in Honduras, where we were just doing the most basic stuff. Now they're doing laparoscopic surgery, and they want to do it better. So in a few short years, 20 years, they now run a very, very effective program with community outreach and research and publications. But that's not typical. In fact, that's kind of rare. And this is what we see actually more often. And so we think, well, what is the problem? Maybe it's the patients. Why are we having complications in most of the places where we work? 20% more complications than we see at our own home place. What is it? Is it their nutrition? Is it malaria? Is it parasites? How do we start to deconstruct this thing so that we know what the problems are and we can begin to address them? Is it because they are living and cooking in these kinds of conditions as they do even today in Jos, Nigeria? This particular picture is of a lady cooking on the hospital grounds in Jos. We were doing a workshop, and there she was just outside cooking for her family, and the patients were in the hospital. This is not atypical. And you can see why they have a whole bunch of other problems in addition to whatever we were working on. I mean, there are kids being burned, there are pulmonary problems because of the smoke, there are general conditions of poverty. So it's clearly not sufficient just to take teams. So we thought, okay, well, maybe it's the system. Maybe it's the supply chain. Maybe it's poor administration. Maybe it's general poverty. Maybe it's parts of this system that we haven't even started to look at. Maybe we need to step back from the operating room. And as Dr. Rodas has said, maybe there are things about the surgical ecosystem that we need to know a whole lot more about in order to make it work. Maybe the reason why we can't get good x-rays is not just because we can't anymore get film because everyone's going digital. Maybe there are more systemic problems. Sterile supply is a big problem. And what do we do to sterilize our instruments in this kind of an autoclave? How do we guarantee the kinds of outcomes that we intend to have when this is what they're using in the hospital in which we work? So maybe it's us. Maybe it's that we've worked well with our friends and colleagues in other places, and as soon as they get the skills, they bail. they move, they migrate. How do we think about what it would take to make them happy in the places where they live and work and stay there and teach? What about the system makes people want to move? Whether that's in the United States or whether that's from Kenya to South Africa, from South Africa to the UK or Australia, all the people who come from outside to the States and don't go back, what is it about this system? It's great to train other people to be like us, but maybe the problem is us. There are both internal and external factors. There's internal and external brain drain, but there are all these other factors that impact on surgical care. It's the technology. It is the business end. It is the social system. It's the legal system. And in this conference, we're trying to address all of those. So maybe it is the technology. And maybe there's some better technology that can work for ventilating our patients. Maybe the problem is that there is energy poverty, and that in many places where we work, there is no reliable source of electricity, and the lights go out in the middle of your case in the middle of the night, and there you are stuck. And you can see in Africa where there is not electricity, this is a kind of a big problem. We have been doing telemedicine outreach. I think Dr. Rodas is well ahead of us, but even in the University of Utah, we're doing this with Rwanda and Haiti. But we've got our problems back in the States, and plenty of them. And we know from just a couple of days ago that, I mean, this is really pretty recent slide from 2 days ago at the International Federation of Health Plans, that our own system on the far right is more expensive than we can afford. So on the one hand, we have a system that doesn't work in the low-resource countries because it costs too much. And on the other hand, we have a system right smack here that doesn't work because it costs too much. So we know from last year's conference here that a cataract operation can cost as little as $100, but we also know that in the States, it can cost as much as $8,000. And we have a problem with waste. These are the 3 bins that are set up typically in my OR, and I don't show a picture of the red bag waste, but I'll tell you the number of bags of trash that go out daily. All that stuff has to come in, there's a cost to it. And all the stuff that goes out, there's a cost to it. And the cost to our system is huge. The burden of disease, and including surgical disease, is heavily weighted in the poor countries of the world. But the human resources for health is heavily weighted toward us. This conference is really about modeling the surgical ecosystem. We're here to think about how we can do this better. We travel around the world to work together. We travel by plane. We've got our satellites. We can go by boat and ship our stuff. We can now communicate because in most places we have good fiber optic cables and 3 new ones on the east coast of Africa. So finally, all of a sudden, we can start talking to some of our colleagues in Africa who they couldn't afford the satellite. The bandwidth was too expensive, but now they've got fiber optic. They are starting to be able to talk with us. So we can now support communications, and we don't require the landline. We are now going wireless for that. We can support the supply chain with less corruption because we have wireless communication. So we've got some things coming on strong. The energy problem is still a big problem. And when I've last heard from people in the health ministry in Uganda and in Kenya, in the remote parts of those countries, in the central parts of Africa in particular, their big problem is still energy. And we need to consider that, and we need to consider how we can design systems, not just for them, but for us. We will have energy problems if global warming is a real thing, and if we keep having hurricanes and we keep blowing out the energy system to half of New York City. We need to do this for ourselves as well as for the people around the world. So I'm hoping that the people here will engage in this dialogue and start exploring how we can do this better. So I think we now have a break. We'll try to fix these technical problems, and please take a look at all the posters and visit with our vendors, and we'll reconvene in a few minutes.